Neņemšu to mikrofonu, nepatīk. Tātad, tie, kas nezina, bērnu slimnīcā mēs realizējam jau gadu asinsvadu komandas projektu. Un asinsvadu komandas ietvaros pagājušajā gadā organizēt meistarklases ar manu uzrakstījumās un Amerikas tenisu. Piedāvāju, ka viņš var mums atbalstīt. Esam kaut ko jaunu sākuši. Nu, es kā kārtīgs latvietis, apmēram nedēļu vai divas staigāju apkārt un domāju, vajag forši man uzrakstīt no Amerikas māsu. Tagad viņam varētu pajautāt. Pajautāju, ko viņš varētu izdarīt. Nu, ticat vai neticat, viņš šobrīd ir šeit. So, Dennis, you are here. Somehow we met each other online.
You found me?
Yeah, I was following you.
Yeah.
Un Dennis ir māsa no Amerikas, kas strādā. So how long experience do you have as a nurse?
2012. So 2012 is when I started.
As 2012, and vascular access?
2020. So I've been doing ultrasound since 2016. And then 2020 is when I started vascular access, central lines, PICC lines.
Okay. So
Translation needed? No?
No.
Oh, perfect. All right, we can move fast. Let's get rid of this PowerPoint. All right. So advanced flushing, we know flushing, we've done flushing. How many years have you done flushing with your fingers? How many years? Yes. You've been doing it for a long time. Good. So we've been doing flushing for a long time. How many years have you been walking? Don't answer that one. Many years, right? How many of you took a class on walking to do better? No, we don't do it. We've been doing this for a long time, but there might be something better. We just haven't looked because we did not see it as a problem. How many of you heard the term, why fix something that's not broken? Why fix what ain't broke? Why fix it? No, don't do that. It's not problem. It's okay. Have you heard that before? When there's new techniques and new ideas in work or at school, we don't fix it because we don't know it's broken. We just let it happen. We don't change our practice because we don't know the patients are suffering. How many patients love getting IVs? Yes, give me more. Give me more blood. You want more blood? Please use more needles. How many patients said that? No. We've all just accepted it. It's normal. I just have to poke you 6 times, 12 times, 20 times. Whatever. It's a problem. So I'm going to hopefully let you guys see some ideas of how to fix this problem called vein depletion. We are ruining their veins. How many IV therapy medications were there 70 years ago? 10? Some, right? Saline, hypotonic, glucose, hydration, that's it. Now there's over 400 IV medications. Now we're poking them more. Now we're drawing blood more. And because we're doing these amazing therapies and amazing innovations in technology and medicine, we also have a new problem. It's called vein preservation, vein depletion. We're ruining all their veins, and it's starting at infancy. Neonates, NICU, PICU. So we need to start paying attention to what we're doing because it's getting worse and worse as we increase we get IVs for being drunk. Hangover. Right? So there's IV therapy everywhere. So let's start paying attention. Here's the problem. We're flushing too hard. Pulsatile or laminar, when do you use it? That's more theoretical. Catheter extravasation and blood reflux. Okay, so blood's going into the catheter, you don't know it. And catheter's coming out, and you don't know it. We call it something different, and we'll go over that. Low pressure for laminar, here's a solution. Low, gentle pressure for PIVs, pulsatile with a little bit of extra pressure on CVCs. Adequate vein purchase. You need enough catheter in the vein. And of course, correct clamping sequence to make sure that you don't reflux that blood during your care maintenance. All right, so let's talk about high pressure. Master students, what is Virchow? Interesting, right? Don't feel bad. I did not know about this until about maybe 3 years ago, okay? Virchow's triad. Virchow discovered 3 main problems that cause thrombosis: stasis of blood, endothelial injury, and hypercoagulability. Okay, so when the vein is damaged, when the blood slows down or stops, it starts to create clots. We know this. And also the disease. We know this, right? So these are just a way to categorize. Please say yes to this next question. Did you know that there is blood in the vein? Okay, you know what? You're the first one to say no. All right, so so we got blood in the vein. Did you know that there was a line inside the tunica intima called the endothelium, right? Did you know that there is something in between? The glycocalyx protein is protecting the veins from the blood. What's in the blood that causes damage to the veins? Medications, thrombosis factors, clotting factors, 1, 2, 3, 4, 5, 6, 7, right? Inflammation, white blood cells, all these things cause damage to the cells. The glycocalyx protein pushes it away, just a very thin layer. So if we get rid of that, we're going to start having clotting and inflammation. So this is what this is. Don't worry, I'm not expecting you to fully understand glycocalyx protein. Just know there's something in between, and we may be damaging it. So let's talk about that damage. Is that a knife? Is he cutting his skin with the knife? No, it's not a knife. What is it? What was that?
It's a pressure from the water.
From water. Here's water. Did I just cut my mouth? No.
It's a high pressure.
High pressure. So, what are we doing when we push too hard with the flush? What's happening in the veins? Yeah. So, when you flush too hard or too much, what happens? Does the vein expand or does it collapse? When you flush hard, it expands. That's what we think. That's what I thought. Because when I was trained, they said, okay, put in the IV. This is how you know it's bad, when it's blown. We use that word blown. And so I thought the vein ruptured. The vein blew up, but it doesn't. It does this.
Your lines, your PIVs are clotting because the endothelium is being damaged by how hard you're flushing it.
And as you can see, there's a little bit of damage.
That cement gets degraded and damaged. Same.
Do you see the veins collapse?
Endothelial lining. What happens when you damage the endothelium?
Look at the veins.
lining of
They're
your vessel?
closing.
You start to develop
They're not
clots.
expanding. They're closing.
Healing.
Alright, so here's our baseline image.
Here's another picture. Here's a catheter. Here's our vein.
Flush.
The vein walls. Right there and right there. So look at what happens when I flush very hard with the 10 milliliter syringe. And you're going to find out today what too hard is.
This would be slamming the flush. I'm going to measure it to see if there's any spasm. Thank you. That's from slamming it like I used to in the ER. There we go. We'll compare this
Look at the difference.
to what it was before.
What happened?
To see if the vein shrunk at all from the flushing technique.
The vein became irritated and it spasmed, venospasm, just a little bit, not enough to completely block it, but it was irritated. We made it angry. We didn't relax it. We stressed it out. Okay, so there's something going on when we flush too hard, and we're flushing too hard all the time. We, meaning me and my emergency friends, maybe some ICU, we'll see. So shear force, when there is shearing, there's friction. When there's friction, there's damage. So this study showed what happens when you flush too quickly, and also what happens when the catheter is sitting like this in the vein. So, am I going to go through the math with you? Yes, of course. This is the graph that shows you. However, it's too early or late in the week to worry about math, so we're going to skip over it. Just know there's proof. Okay? Just know that there's data collected around what I'm saying. I'm not that smart. I'm not smart. I did not develop anything that you're going to see today. I'm just copying what other smarter people figured out. Okay, they're telling me these things. That's it. I didn't discover anything. I'm just sharing what other people have discovered. Catheter extravasation, when the catheter comes out, what happens to the liquid? Has anybody had an IV where they flush it and it starts to bubble? Like a swell? Right? It looks like it blew up. It looks like it exploded. It didn't explode. It just came out and then it leaked outside of the vein. So instead of going into our heart and circulatory system, it just stayed there and started to swell. That's what's happening with the extravasation. So if your catheter is only 2 centimeters, is that long enough? Of course, you're going to think no, because I'm making it short length. Let me show you why it's not long enough. Take your skin on your arm, and I want you to do this. How many centimeters are you moving? 2, 1, 4, 5. What about our elderly and what about our previously obese? They're going to move kilometers. Okay? So if that catheter is this short and we put it in the vein, oh, it's good. Good blood return, good flush. Their skin's going to pull it out of the vein. You can glue it to the skin. You can staple it. You can melt it. And it'll stay in the skin forever, but the skin will pull it out of the vein. Something to consider. Maybe we need to have different equipment, longer catheters possibly. So here's what happens when the catheter is extravasated. This is not from a textbook from the 1970s. I took that picture with my iPhone on the left. This is a patient that I had. That is another picture a friend of mine sent me from his work. It was crazy. This is still happening today. And it's not the patient's fault. It's not the valve's fault. It's our fault. We're doing this. We're causing this. Guess what medication this is? I'll give you a hint. It's an antibiotic. Which antibiotic? Vancomycin. Have you given vancomycin before? Did this happen? No, because you were a good nurse. If there was a problem, you said something or you fixed it, or you had a good IV and it worked well. Or you did the right thing and put it in a central line, right? So that's extravasation from peripheral IV. This is the danger of the pride, the ego of, I've been doing this for 200 years. I know what I'm talking about. I know what's best. This is the problem. That 30-year experienced nurse, and it's not about the experience, it's about the ego. I don't care if you've been doing this for 10, 5, or 20 years, the ego is the most dangerous. So, patient said, hey, it burns a little bit, not too much, but a little bit. I can tolerate it, but it burns a little bit. Nurse flushed it, it was fine. She said, no, it's vancomycin, it's supposed to burn, we're going to keep it going. So, she kept it going. Then another day went by and she said, it's burning a little bit more now and it's like a little warm, like it feels hot. No, it's flushing. Nurse said, no, it's flushing, it's normal. Vancomycin is supposed to burn. Everyone burns with vancomycin. We're going to keep it going. And then she started seeing swelling, more redness, more pain. And the nurse again said, hey, it's normal. Like, it's flushing well. Don't worry about it. I can't draw blood, but who cares? IV's not supposed to be able to draw blood. We flush it. It's fine. And then it got so point after 1 week of extravasated vancomycin, maybe even less, because I came way after. This is what happened. This is tissue necrosis. This is dead tissue because the nurse neglected that patient. In fact, it was malpractice. The nurse said it was normal when it was not. This is a big issue. Same thing with this. What happened here? Do you see that? It's a blister. See blisters here, blisters right there. Which beach do you go to? Which beach do you go to? Huh? Around here? Yes. Okay. So, when you lay down on the beach for too long, what happens to your skin? It burns. There's a blister. This is a small blister. Do you go to the hospital? No, you're a nurse. You pop it and then you put a Band-Aid on it, right? That's normal. Now, that's because with the sun contact radiation burn, the skin is the first thing to get damaged. Everything else is fine. But with an extravasation, the skin is the last thing to get damaged. The last. What does that mean? Everything else inside is damaged first. Now the skin is damaged. This is a very, very, very bad sign. We had to cut this man's arm off. He doesn't have an arm anymore because we let this happen. We let this happen. Okay, so this is neglect. We need to listen to our patients. All right, so this is also what happens to kids too. When we don't make sure that the IV is in well, how do you know? The best way for me is ultrasound because I can see it. But if you can't see it, then how do you know? You have to pay attention to these symptoms.
Paired by most CT protocols to deliver the desired image quality. Extravasation is an undesirable complication.
Look at that. This is not AI. This is real.
Catheter placement, catheter movement inside the vessel, unhealthy vein condition, or even the impact of contrast on the vessel at high flow.
Look at what happens to the catheter when you flush with too much pressure. Look at that. That's just water.
Image quality.
That was only water. Water was able to push a human being out of the way. What's it going to do to our tiny catheter? Did you guys ever send patients to CAT scan or CT? Do you guys do that? Do they always come perfect with the IV still working? So that's what's happening. It's coming out because of the pressure, the viscosity, all that physics. It's pushing the catheter out. It's not blowing up the vein. It's coming out of the vein. Now, whose fault is it? Whoever put the catheter in, right? We chose the catheter size, we chose the vein, and we let it in there. So, not saying that you're evil or I'm evil. I'm just saying let's find out more to prevent that from happening. Okay? There's ways to prevent it. All right, so friction from catheter pistoning is also another issue. Ultrasound. I'm so excited for you guys to be learning ultrasound because this is one of many studies that have showed the improvement of outcome with ultrasound. How many days do your IVs last? Yeah, of course. What's the longest? Okay, let's say 5 days. 5 days with ultrasound, 10 days. 3 days with ultrasound, 6 days. Now, is ultrasound guaranteed it's going to be better? Because I'm still holding the needle. If I'm terrible and I'm not good, the ultrasound's not going to fix anything. The point that I'm trying to make is it's the equipment increases our potential for success. It doesn't guarantee it. We guarantee it. How many times did I practice so that I'm good? How many decisions did I make that was better? It's still us, but the ultrasound lets me do this much, or the potential for. So, pulsatile versus laminar is another issue. When do you do pulsatile? When do you do laminar? Do you know why we do push, pause, push, pause, push, pause? Do they teach you that right now? Push, 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 or one push? One push? Interesting. So the reason why we push, pause is it helps to create turbulence inside of the catheter. Can you take a catheter and then clean the inside? No. So we need to use saline to help clean it. And pulsatile increases that shear force. But that turbulence, that shearing, also happens in the vein. And so with the peripheral IV, recommendation is to laminar flush, slow, gentle flushing for PIVs. For central lines, so for CVCs, do pulsatile. That is best for it. Because here, there's so much blood and the vein is so big, you're not going to really shear anything. Okay? All right, so here's why you don't push too hard.
Here we go.
Look at what happens to that catheter. There's a 4 French single lumen catheter. If I can move it this much, What's happening inside of the body? So, where's the catheter?
It hasn't dropped yet.
There we go. That's how much it can move up and down the SVC or the IVC. Where's the central line supposed to end? It's supposed to go like this or like this, right? So what happens if I flip it up to the neck because I push too hard? That's one reason. Another reason is if the patient coughs a lot, they can flip it up. If the patient is intubated and the ventilator pushes a lot, that can also change that thoracic pressure and cause it to flip up. So there's many, many different ways, but one of the ways is us. So let's not overpressurize it in the CVC. All right, so why laminar flushing? We talked about that. Again, this is the study to explain the theory of laminar for PIVs, pulsatile for CVCs. Okay, we have seen this. Which syringe will help you? Let me see. 3 is here, 10 is here. Which syringe is going to help you push with the most pressure? Which one's going to be easier? This one or this one? More pressure. This one. Okay. Smaller one? Big. Okay, there's a debate. All right. Okay. So the smaller one is going to input or be able to make it easier for you to output more pressure. Now, if the small one outputs more pressure, which one will be able to output less pressure? The big one. It's the small one again. Yes! Don't worry, don't feel bad. I did not know this until 2 years ago, okay? And how many lines have I been flushing and having it come out? So it is 3, let me explain. This is why. The 3 milliliter, the smaller milliliter makes it easier, keyword easier, to exceed and get very high pressures, and it makes it easier to get very low pressures. And you're going to experience this during the workshop. You're going to see it during the workshop. This is the math. Welcome to physics. Poiseuille's law. This is the change of pressure, okay? Don't worry. I'm not going to go too deep into the math. I just want to let you know there's a mathematical proof explaining all this, okay? Again, I'm not the smartest person. I didn't make this up. I'm just spitting back what other people have told me. When we look at this, it's so cute. It's like a little baby. Right? We only use a little bit of medication. It's so adorable. It's like the baby brother of the syringe, right? No. It is a powerhouse. It can do way more good and bad than a 10 cc or a 50 cc syringe. Let me explain. Q is us. We still control this. We still have the most important factors Q, how hard we're flushing. All right, let me show you what happens.
This is a 3 cc syringe. 100.
Okay, who cares? What's 100 something? 100 milligrams is not that big, right? 100 millimeter? Millimeter's not that bad. What is this? What is this picture of? Yeah, but what is this whole thing? It's a car tire, not a bike tire. What did they say the maximum was supposed to be? 51. What did I do?
This is a 3 cc syringe. 1.
Okay. This is a car tire exploding at 170. What did I do?
This is a 3 cc syringe.
168.
100.
Okay. This is a car blowing up at 170. What did I do?
This is a 3 cc syringe.
Okay.
1.
So, does this mean if I flush too hard with a 3 milliliter syringe, is a patient's arm going to blow up? No, because you've done it before. Okay? It's not going to blow up because the volume is different. The volume of air with the tire is a lot of volume. This is tiny bit. So the punch is a lot less because the volume's lower, but what are we doing at the cellular level with what we're doing? The scale, think about the scale of it. We're still able to output 168 psi of pressure. I think we can do a little bit less. Don't you? So let's discover that today. All right, so advanced blood aspiration. How many of you draw blood from the peripheral IV catheter? Yeah? First stick or after 2 days, after 1 day, you still pull?
First.
Only first. Why not after day 2? Why not? If it works the first time, why doesn't it work the next time?
It's already with the medications and all that stuff.
What does the medication do? Does it melt the catheter? I hope not. So this exercise, this presentation, what you're going to do today at the workshops, trust me, that's the more exciting thing. I'm happy to get you there. This is going to help you discover there's more to this vascular access than I know. And I want to take you to the rabbit hole and figure out what's happening. So hemolysis is happening. My recommendation, low pressure. If anything, if it stops pulling blood, pull, pause, pull, pause, pull, pause. What does a pause do? Let me show you. When I aspirate, it goes, ready? It closes, so if I hold it while it's closed, is it going to help fill with blood? No, you've closed it. It's a valve. So you need to give the blood time to fill that vein back up. So pull, pause, wait for the blood to fill up, then pull a little bit, wait for it to fill back up, okay? So we're overcoming the pressure in the vein. We must pull with less pressure than what's in the vein. All right, so barotrauma, I used to call it cavitation. I was wrong. My friends have corrected me online aggressively and gently that it was barotrauma. Barotrauma is a technical term for when the cells and tissues being ripped apart because of the negative pressure. Watch what happens here. Now, before we go into the video, this is a problem I hear all of Latvia, all over the world, all over the Baltic region, all over the galaxy, all over every nurse in the universe has this problem. When we draw blood and lab calls and says, hey, I'm so sorry, but the blood is hemolyzed. And what do? It's your fault. We blame it on the lab, but what we need to remember is that the hemolysis usually happens before it gets to the lab. When I was in the emergency room, my trainer said, if the blood tube, when you fill it up, it's clogged, it's no good. It must be liquid. I did not hear her say, only some tubes must be liquid, right? So what did I do? When I saw the red, you guys have red colored tops? They're okay to clot, right? It's supposed to congeal, but I didn't hear that. So I was like, okay, good, and I send it. That's the problem. So when we drop it, okay, things like that, the trauma, a lot of what we're doing before it gets to lab is causing these hemolysis issues. So this is the definition of barotrauma. I think most problems are from when we're pulling, and I'll show you why.
Here's a great example of what's happening.
Look at the bubbles.
When we pull with two.
And I want you to tell me how big the bubbles are getting.
Blood is hemolyzing. So I'm going to suction that.
How big are the bubbles getting?
Plunge with negative pressure. Look what happens to the bubbles.
Do you see how big those bubbles got? Now imagine a tiny, tiny, tiny cell, and we're doing that. What's happening to the blood cells? We are hemolyzing. How many of you, when you were drawing blood, you were like, ooh, I'm getting it, and then, no, oh, give me that blood. And you guys pull hard. I used to do it all the time because I was like, you're not going to beat me. I'm stronger than you. I'm going to get that blood. And it came little by little. And I was like, yes, I'm getting it. Have you ever noticed when you draw blood with the syringe, sometimes there's bubbles coming through? Did you ever notice that? Central line, right? Yeah, it happens. That's called barotrauma and maybe cavitation. So what we're doing is we're pulling with so much negative pressure that the gases are forming by themselves. That's 100% going to be hemolyzed. If you see bubbles, it's not leaking, it's something else. All right, so when we do this, we have to be careful because these cells are going to break. When we stretch these, is this red blood cell any good? It's bad. It's hemolyzed. So be careful how hard you're pulling that syringe. Be gentle as possible. All right, so average normal pressure, master students, homeostasis, what is that? We went beyond homeostasis. Homeostasis is what is normal inside of the body, or what the body's functioning with. If the blood functions at 2.3, what are we doing when we pull it out of the blood to 1? Atmosphere is 1. 1 atmosphere, or less depending on how deep you are on the water. So if that blood tube is sitting here and I'm like, okay, I got the blood, I'm gonna go take a break, have my lunch, have a nice little snack, talk to my friends, take a water break, and then, I forgot, I gotta send it over. What's happening to the blood? The blood is not quickly, very slowly hemolyzing over time. So the longer we wait to send it to lab, the more likely it's going to fail. Luckily, there's preservatives in there to help prevent that hemolysis, but it's still happening. Also, when you fill that tube up, you know that red tube and the purple tube, when it goes, and you're like, it's not finished, it's not all the way, it's good enough. The lab says, I only need 1 or 2 milliliters, that's it. What's in there? What else is in there? Negative pressure. How do you get the blood in the tube? Negative pressure. So there's still extra negative pressure in there. So that's constantly ripping that red blood cell. Best thing to do, just pop it off, put the top back on, and then send it. Neutralize that pressure. Okay, so that's one way that you can reduce hemolysis. Here's a study showing the different hemolysis rates based on different negative pressure. Okay, all right, so it's not just about amount of pressure, it's about amount and how long we're holding that pressure. Time and negative pressure both increase hemolysis. So we have to consider this. Reconsider understanding the devices that we use.
Let's look at baseline to see what kind of negative pressure it applies.
Okay, so that's with the regular tube, a Vacutainer tube.
-4. Now let's see what happens when we pull it with a 3cc syringe.
-9
Look
with my skinny syringe.
Now let's try with the 10cc syringe. -13. And then we had...
Okay, so it's pretty big, it's significant, it's not a little. So that's why if you hold that syringe, the time and the amount of negative pressure is high. But if we do a little bit, wait. So -2, 0, -2, 0, -1, 0. If we do more gently, we're reducing the time exposed to that negative pressure. All right, ANTT, please tell me you've changed dressings before for central lines and PICC lines, right? Okay. Look at how much that catheter is going in and out of the skin.
After preparing the skin with a skin protectant prep pad, fix the CVC with a sutureless securement device.
This is actually really good. It's better than me. Is this possible to prevent that catheter from going in and out? It depends on the devices you have. So when we're changing the dressing, do you guys use the adhesive securement, or do you rely on the suture or stitches? Which one do you guys see? The stitch? Stitch? Okay. So with stitching, the catheter is not going to come out. I mean, it could if you pulled hard enough, right? But most likely the catheter will not move. What's happening when we clean that skin? We're removing the skin. So even though the catheter is not moving, we're making the skin go in and out. So we have to be careful with that. Not only that, when you have sutureless securement, one time, because we have the adhesive, we don't use lots of sutures. So one time I was like, oh, I'm cleaning it, it's nice and clean. And then it came out like 3 centimeters. I'm like, right? So that happens, okay? So we have to prevent these infection risks from these small little things that we do. All right, so here's sutures. They're not perfect. They will not always work. When the doctor says, oh, sutures are the best thing to use, no, it's not. Okay, there's better devices out there. And this week I talked to the physicians on options and ideas on how to prevent that problem, and hopefully they'll have access to it. So, chlorhexidine, alcohol, or iodine, what do you use to change your central lines? Huh? Okay, good, chlorhexidine. What happens to the skin when you keep it on for too long, while wet? If the chlorhexidine is wet, or the alcohol is wet for too long, what happens? Huh? Yes, it's called a chemical burn. We like to say irritation because it feels nice that we're not actually hurting the patient. It's chemical burning. That's going to cause a rash, and the rash is going to cause an infection. Now we have to pull it out, or pull it out, or pull it out. So you must let the chemical dry. It is the most painful part for me as a nurse. It is the most painful part of the procedure. God, I gotta wait for it for how long? No! We're so tempted to go, right? We do everything we can to get that to dry faster. Whatever you do, you gotta let it dry. Okay, don't blow on it, and we're gonna show you that in a second. Is this normal? It's not good, but is this familiar? Have you seen this before? You're telling me your dressings were perfect all the time? Did it look like this all the time? What do we have here? We have all the equipment we need to keep it from getting an infection. We have antibacterial skin or disc. We have the tape, and we have securement with the suture. What about here? We see stitches. We see the antibacterial disc, and then we have the dressing. All the equipment needed to prevent infection is here. You only need those three things, but does this look like it's gonna stop infection? What about this one? This has everything too. You have stitches, and then you have the antimicrobial disc, and then you have the dressing. But this doesn't look like it's gonna fix an infection or prevent an infection. Why? Because it's disrupted. Even though we have all the equipment, it's still up to us. Now, who's responsible for this? The nurses are responsible. Wouldn't it be easier to take care of this? Right? Why? Why is this easier? It looks neat, but why is it neat? These are
applied correctly.
applied correctly.
And the skin was dry.
Do you see it's dry, but what do you see the difference between this and this? Don't worry.
Out the different directions.
Yes. How much money did it cost for me to change direction? $0. It cost me $0 to change. So I start inserting it this way because it's easier for the nurses to change the dressing. Now, you said the nurses are responsible for keeping that on there. That means that the nurses ultimately were responsible for the infection. We are responsible because we did not keep it clean, we did not keep it intact. But that's not fair. Why? Because it keeps coming off. Why does it keep coming off? Because gravity doesn't take a break at 7 in the morning or 12 in the morning. It works all the time. So, the nurses are ultimately at fault for this patient's infection. However, the physicians are first at fault because they put it in. When I put these in wrong or suboptimal, I'm responsible for leading the nurses to failure because it was impossible to keep that clean because I put it in wrong. Now, luckily, I spoke with many of the young physicians here at this area at the conference, and we went over all the different techniques with the different presentation. I shared with them as many ideas as I possibly could to help it make it easier for you guys down the road, okay? But ultimately, it's the physician's fault first, then second, it's the nurse's fault. We're all responsible. I'm not trying to point, say, you're evil, or you're bad, or you're bad. No, we're all bad. We're all responsible for the patient outcome. Is the patient there like, no, let it sit out. No, don't fix it. Leave it alone. No, patient doesn't know. They can't be responsible. So, how many doctors have you heard, don't answer this, say, no, nurse, what did you do? When I left, it was beautiful. It was on there perfectly. But then after 6 hours, I leave and you mess it up? That's what they think. They think this foolishly because they never changed the dressing. I guarantee you, never going to happen. I guarantee you, if we make the inserters, nurse, doctor, RT, tech, I don't care who it is, if we make them change the dressing because it's coming out, they'll fix it very quickly, right? But it's the nurse's it's the nurse's job. Ugh, it's not for doctors. That attitude is what makes it dangerous for the patient. Now, here's why I poke and pick on my physician friends. Trust me, my cousin is an interventional radiologist, doctor. My uncle is a trauma surgeon, blah, 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 blah. I pick on them because they are leading the team. If you're putting these in, you are a leader. And if you're a leader, you have to do better, or else the rest of the team will fail. Right? Now, for you, nurses, when you put it in here, when you insert that peripheral IVs, right, and you tell the patient, don't move your arm, right? Oh, what do you do? What happened? When I left, it was beautiful. The dressing was on good. And 6 hours later, what did you do to make the dressing go bad? What did you do to make the catheter go? I told you not to bend your arm. Now whose fault is it first? It's the nurses, right? When we flush, when we change the dressing, all these things. So I want you guys to see, it's not just the doctor's fault. It's not just the nurse's fault. It's all of our fault. Let's figure out how to do it better. Instead of ignoring, saying this is normal, let's make this normal. Let's make this normal, right? So there's other little things that you're doing in your nursing practice that will lead to better outcomes for the patients. We got to stop blaming the patients for this. We need to start taking responsibility. So let the skin dry. These are all the different ways that you can improve. So infection complications is one of the biggest things. We maybe not know this because I don't know if you're collecting the data in Latvia. Tell me, what do you see here? Two guys, two gentlemen. Is that glitter? What is that? What is that? What do you see?
So particles.
Particles of glitter?
No,
It's a bacteria, like from the...
Huh?
like a cough, something like that.
Uh-huh. What is it? It's spit. Right now, as I'm talking to you, I'm spitting on your face. Actually, I am. You got lucky. So, this is what we're doing when we don't wear a mask. When you're having dinner with your friends, you're eating each other's spit. Who made that noise? It's happening all the time. The reason why we didn't think about it is because we didn't see it. See no evil, hear no evil. Now you see it. You're welcome, and I'm sorry. Okay? So this is what we're doing. So when you change your central line dressings, your PICC line dressings, are you wearing a mask? Don't answer that. When you are inserting, ready? Inserting, oh yeah. And you're dragging, oh yeah. And it's going in the skin and into the vein. Are we wearing a mask when we're doing this? Are we wearing a mask? Let's say this is an IV tubing, okay? Catheter. This is a catheter. Are we wearing a mask when we flush? Are we wearing a mask when we connect the medication? How about this? Let's go a step further. I have alcohol swab right here. Okay, this is a real cleaner. It's not fake. Oh, it's real. Okay, so this is the IV tubing. How long am I supposed to scrub? 30 seconds? Anybody want to say 15? Let's say 15 seconds. Hey Siri, set a timer for 15 seconds.
15 seconds. Counting down.
You almost said 45. That is so painful. Are we actually scrubbing for 15 seconds? Right? And then let's say we scrub for 45. Let's say we scrub for 2 minutes. She's like, God, he's spitting on my face right now. So let's say we scrub for 2 minutes. And then I breathe and then I talk. What did the scrubbing do?
Nothing.
Almost nothing. Something, but not after I keep spitting on it. So let's wear a mask. Trust me. Trust me when I say, you do not hate masks more than me. When I was in the emergency room in Baltimore, a patient came in with tuberculosis, came in with COVID, came in with meningitis. I didn't wear a mask. I said, what's the point? They don't tell me until 2 weeks later anyways. We don't even know. Who cares? I never got sick. In the emergency room during COVID, I never got sick and I didn't really wear a mask. I was in that isolation room with no mask, doing my thing, and I never got sick. So I was like, I hate masks. I don't need it. Do you know when I wear a mask? When it smells really bad. And I put toothpaste, right? So wear a mask. It's not to protect us. It's to protect the patient from us. Okay, so let's consider that. This video changed my mind. Remember, I've been doing this for a long time. I've only seen this video 3 years ago, and I was like, oh, I didn't know. Okay, so let's change it. Now, don't worry, you guys will have access to all the videos. If you want to make your own presentation, email Linda and she'll send you a link to the PowerPoint. You can translate it, you can edit it, you can take things out, add things in. You can use it for your own, whatever you want to do. Pressure ulcers, quick fix is just gauze. Put gauze underneath it, okay? So, catheter reflux. This is also another thing that we don't know because we don't see it, okay? Catheter reflux, this is going to be interesting for you guys, what is that? It's a fibrin sleeve. It's fibrin. And what it did was look at what happens when I try to flush it too hard. It made it longer. It brought it out more. I tried to aspirate and it crumped up when I tried to draw blood. Can I use this for infusion? Why not? You can. Why not? You can still give medication. There's no thrombosis. There's no clot. If I didn't look with ultrasound, would you have known that there was a fibrin sleeve? No. This is a peripheral IV, not a midline. Peripheral IV here in the forearm, 22 gauge. Use it. So when the nurses say, hey, I can't draw blood, go look at it with ultrasound and see, oh, is there a clot or is it something else? So then I say, yeah, go ahead, use it. It's not a problem. Now, if there was a thrombosis, I say, yeah, we might need to find another IV, right? This is the power of ultrasound. We can see what's going on. All right, blood reflux. When you guys use your IV catheter, do you have the tubing, the extension tubing? The little tube? Do you have a clamp?
A lot of you have probably seen this. Wow, look at that.
That part. Do you guys use that?
We're going to simulate flushing technique.
This is the clamp.
One more time, just to be sure. Okay, now I want you to keep your eye here while you watch me disconnect. This is going to be the key part, right? Most people do this. They take the hub off, they take the hub off, they take the hub off.
Look at how much blood went inside the catheter.
Look at all that reflux.
Okay, do you see how much is inside the catheter? Central lines, you're not going to see this because it's too deep in the skin, it's too far down. This is what's happening. So if this is sitting in there, let's say I refluxed it and I clamped and I leave it alone for the next shift, next 12 hours, what's going to happen? We're going to start to develop clots. And enough times, maybe not the first time, you can flush it away, maybe. Third, fourth, fifth time, it's going to be occluded and you're going to say, oh, it doesn't work. I don't know what happened. This is part of what's happening. Not all the time, but this is part of it. Okay, so we want to be careful about when we're refluxing. So when they told you, did they say clamp and then remove, or remove the flush and then clamp? Clamp and then remove? Yes. At the same time. Yeah, and then you remove it. Okay, depends on the device. Okay. So
here's the.
I'm going to skip this one. Any NICU? Neonate? Okay.
So that's a.
This is how many different devices there are. And this is how much they're refluxing. So these these three are not available in the US or in Latvia. I'm not sure if this one is either. But does any of these look familiar? Right? So if you're not clamping properly, like this one, positive, positive. These, and I'm not sure which one else, positive displacement requires you to flush, disconnect, and then clamp. If you clamp early before disconnecting, the septum will stay open and things are going to go inside. Bacteria, spit, everything. So you need to know which device you're using for the right clamping sequence. Anti-reflux, it doesn't matter. Unfortunately, it's not here in Latvia yet, but just know there's other technologies out there. All right, anybody use portacaths or needles? It's always you. So portacaths, just know they have reflux as well. You want to make sure that you're flushing while removing that portacath. Because if you don't, there's going to be a little bit of reflux here. So the septum moves in and out during the removal, and it sucks in a little bit of blood. And so you want to make sure that you're flushing while you're removing the needle. All right, because if we don't, we're going to cause issues. The flow of the bevel. Who works in the OR? Okay, OR, do you see port insertions? Okay, is it always IJ or sometimes subclavian?
It depends.
It depends. Okay, good. So the catheter is this way with the subclavian, and with the IJ, it's this way. It's basically a tunnel with a pocket, right? So if the IJ is this way, where should the bevel be? Where should the flow of liquid be based on this diagram? The opening of the needle, should it be pointing this way, this way, this way, or this way? Up, down, left, or right? Anybody know? Yeah. Yeah, down.
Yeah.
What about subclavian? Now it's different.
But we do the same.
We do the same, but we're not supposed to. With the subclavian, we have to make sure the bevel is pointing this way. Watch. The green arrow, well, she was saying that she in the OR, they do place subclavians. So it does happen. The green arrow is the direction of flow, and it must be away from the catheter, not with the catheter, because this is what happens. This is why the ports fail, because we don't know which direction that needle is supposed to be pointed. So be mindful of this when you're teaching and educating, where that needle is supposed to go based on subclavian or internal jugular. So, and of course, don't use a regular catheter. All right, so thank you for your time. Linda's gonna go over the workshops. This is the more fun part of today. You're gonna learn so much about what you didn't know. So yeah, thank you for your time.